Next, I'm going to invite two other rising stars, Jimmy Sue and Alexandra Reynolds. Both were a part of the team that puts together technical consideration of using T-series for brain death. That is a consensus statement being worked up by American Society of Neuroimaging, and I have the distinct pleasure of inviting them to talk about use of T-series in brain death. Jimmy and Alex, all yours.
All right, thank you. So can everyone hear me okay?
Yep.
All right, so we'll go ahead and talk about the technical considerations for the use of TCDs in brain death, and this will be a split presentation between me and Dr. Reynolds here. To start off, both of us have no disclosures. I think it's great to kind of step back and look at the history real quick. And so brain death was first described by Robert Schwab, a neurologist at MGH back in 1954. And then the chair of anesthesia, Henry Beecher, was the first to kind of formally discuss what he called at that time the ethical problems created by the hopelessly unconscious patient in 1967. This ultimately accumulated to a nationwide issue with the Uniform Death Act that was passed in 1980. And so we start to see some movement from the 50s to the 60s and now into the 80s. And as a side note, Dr. Azalid was the first to discover that pulse wave ultrasound system could penetrate the skull. And now we were able to measure kind of blood flow velocities in the early 1980s as well. And to put that into perspective, this was the first ultrasound system that was present in the 80s. So as you can tell, it looks a little bit different than the ultrasound machines that we have nowadays. So what about the current state? So we know that brain death occurs when there's a known cause for a catastrophic and irreversible brain injury. And as a reminder, brain death is a clinical assessment. So where does that come in with this talk of TCDs? Well, to take it a step back, the AAN started coming out with guidelines in determining how to go about with brain death. And so the first one came out in 95 and the next one came out in 2010. And so roughly every decade it's been updated. In 2023, they updated its guideline along with a recent updated guidelines from the World Brain Death Project in 2020. And basically, there's a lot of things that it talked about, but in terms of ancillary testing, it decreased the number of approved methods to just 3 studies. So we have a 4-vessel angiography, we have a radionucleotide study, and then transcranial Doppler. So that's all great, but the problem is with the first 2. So with a 4-vessel conventional angiography, it's hard to get a neurosurgeon to do a procedure on someone who's potentially brain dead. In terms of a nuclear study, it's not readily available at all hospitals, and oftentimes we have to transport these patients. And so a lot of the times these patients who are on the borderline of potentially being brain dead, they're on multiple drips, they're very unstable, and so it can be hard to move them around. And so I think that's where transcranial ultrasound has a big advantage. So if we quickly look at the literature, these are the 2 papers that came out recently with the guidelines. So again, AAN in 2023, and then the World Brain Death Project in 2020. And it kind of gives us a little guidelines as to how to go about using ultrasound in brain death as an ancillary test. So you can see in the red underlined areas, it talks about different types of flows. You know, in the AAN version, you see oscillating flows or systolic spikes in large proximal or large intracranial arteries. The one on the right, you can see it talks about looking at both the front and the back arteries, the carotids and the vertebrobasilar circulation, as well as bilaterally, looking at the right and then the left. And it too talks about some waveforms that we may see in terms of oscillating flow or systolic spikes. And just as a quick reminder, I like this kind of diagram where you can see the conventional ways that the waveforms change as your resistance, as your pressure, as it gets higher and higher, ultimately you get no flow. But that's really it if you think about it. And so we talk about all the different ways, and you've heard some of the speakers earlier, and you'll hear some more later about all the different parameters, all the different ways we can use ultrasounds. But as you can see, we really only spoke about maybe what the waveform looks like, or which vessels to do, but not necessarily more in terms of, maybe which probe to use or how long we have to insonate the vessels or things of that sort. And so even looking at other papers, we found that there's a significant gap in terms of how different hospitals, how different cities, how different even countries do all these things. And that's where I think it's important that we try to come up with a systemic way or a systematic way. And so I'll let Dr. Reynolds take over from here.
Thank you, Dr. Suh. So the American Society of Neuroimaging created a brain death task force to address sort of the inconsistencies and big questions regarding technical considerations about this. I think there's a big move in general to systematize brain death declaration so as to keep the public sort of understanding of what brain death is and to minimize false positive declarations. And so obviously as TCD becomes more important in ancillary testing, there really does need to be more formality in how we allow TCDs to be performed. Next slide. So for the first part of our sort of foray into this, we tried to do a systematic review. So we searched PubMed and Embase for articles, and we looked at really all articles that described transcranial Doppler as an ancillary test. And this was both at sort of the inception of understanding what brain death TCDs might look like, all the way till, December 2023, where people were commenting on more advanced techniques. Next slide. And we came up with some questions before we even started, but as we went through the literature, obviously we found more questions than we may have actually anticipated. And so we were able to classify these questions into 5 different categories. So questions regarding how to acquire the images, questions about how to interpret the images, then questions about the patients themselves and the clinical situations that they were in and the appropriateness of using transcranial Doppler. Then because we looked at international studies as well, we looked at legislative priorities. And then there were papers that sort of reported their research priorities. And so we wanted to also understand what other people thought were the research priorities in this domain. Next slide. So we were able to find some consistencies, surprisingly, although when you look at the consistencies, which you can see on this slide, a lot of them were about image acquisition and not even about how to do the study, but really the minimum requirements for the machine. And I think this is something that over time has become standardized. You can't find machines that don't have, specific probes anymore. So while this looks like there's a ton of consistency, unfortunately, I think a lot of it has to do with just using a standardized transcranial Doppler machine and using standard probe locations. The other things that we found there was some consistency with were patients where you should not be using transcranial Dopplers or where there's a high false negative rate or false positive rate. So those were things like using TCDs in the neonatal population or where there's an open fontanelle, using transcranial Dopplers in, we'll call the acquired fontanelle, whether it be hemicranie or a burr hole or something like that, some sort of inconsistent discontinuity of the skull. There was very little information, but consistent information about using transcranial Doppler on patients with mechanical circulatory support. And so you can see, while there is some consistency, this was not the vast majority of the papers that we were looking at. Next slide. Where we found a lot of inconsistency, surprisingly, was in technical questions of image acquisition. So how long do you monitor each vessel for? How many vessels do you need to insunnate for an adequate test? If you don't have a temporal window, can you use an orbital window? Can you use the extracranial carotid and use a carotid Doppler to evaluate the anterior circulation? Other questions regarding the study itself: how much time do you need to wait between the clinical exam being concerning for brain death and using the transcranial Doppler? And then if your transcranial Doppler, you suspect brain death, the transcranial Doppler is not consistent with that, how much time do you need to wait until you do another study? And then while, as Dr. Suh already pointed out, you can see a lot of the guidance is on the use of transcranial Doppler to identify reverberating or oscillating flow or small systolic peaks. We were concerned that there were inconsistencies in the literature of what the technical description of that was, both in terms of, how high is the systolic peak? What is the duration of the systolic peak? There were papers published where they described reverberating flow, but then the image that was published was not consistent with reverberating flow. And so just saying these terms seem to not necessarily be adequate to sort of describe what exactly it is that is being looked for. Then things like minimal training requirements to perform transcranial Doppler for this, or to interpret transcranial Doppler for this. This might be very important in places that don't have sort of the ability to have transcranial Doppler techs. And so who is going to be performing these transcranial Dopplers in smaller hospitals that don't have other resources? And then there were some patient-related clinical factors, such as what vital signs should be required. What's the minimal blood pressure? What's the minimal, what's the appropriate CO2? And then do you need to document that or not? We found lots of variability, not surprisingly, in national laws and national guidelines. And then in terms of research priorities, we found a lot of inconsistencies. And I think part of this is because sensitivity and specificity that were reported with transcranial Doppler very much varied depending on what they were comparing it to. So transcranial Doppler may not have high sensitivity or specificity in a patient who is clinically declared brain dead by clinical criteria and an apnea test, because we hold patients to a higher standard if we're going to be declaring with ancillary testing, and we hold them to cerebrocirculatory arrest, right? So there were a lot of inconsistencies about what should be the gold standard that we're using to compare transcranial Doppler to. Probably shouldn't be the clinical exam, right? Because we're using this as an ancillary test, but then what ancillary test are we sort of comparing this to? Next slide. And then there was very little or no guidance on a lot of questions regarding image acquisition, such as optimal scale, whether you can just use power mode, whether color Doppler flow can be used to screen for diastolic flow in the positive direction, whether the central retinal artery should or could be used. And then interestingly, because of the concern that a patient might have transcranial Doppler windows, but then be interpreted as not having windows when there ceases to be any further flow, meaning absolutely no flow. The question of whether a screening test should be done on arrival of a patient who may be suspected to progress to brain death. There's really no guidance in the literature about that. There's no guidance on who should be performing and interpreting the test. And then patient-related factors, including patients with arrhythmias, and is there any specific consideration in using TCD in that patient population, and or restrictions on medications that can be used before, during the TCD studies. So as you can see, there are a lot of questions that remain to be answered. Next slide. And so I think even though TCD is becoming a sort of bigger option and maybe even more available option, there really is a significant gap in the literature about technical information. And as there is more and more use of TCD to declare death by neurologic criteria, there really does need to be a methodologically standardized approach to using TCD to ensure that we're all sort of seeing the same thing and interpreting the same thing when we declare death by neurologic criteria. Next slide. And so based on the findings of our scoping review, we initiated a national survey of TCD protocols to identify what sort of practices are being done at the institutional level. And because there is very little guidance in the existing literature on a lot of technical details, our next step is to do a Delphi consensus with experts in the field to attempt to standardize the procedure itself, the interpretation of the images, and to be sort of limiting the use to clinical appropriateness so that we limit false positives and false negatives. And because we don't have a lot of guidance in the literature, it really is going to need to be delineation by experts in the field. And I believe that's it. Is that right, Dr. Suh? Thank you very much for your attention.
Yes.